And we have a very special guest from US today. And another two special guests are our two past presidents, Dr. Narasimhan and Dr. Amit Vora, who have very nicely agreed to chair the session today. They will be the moderators. So I just have one more announcement to make, that we have invited a couple of pediatric cardiologists also who are outside the IHRS. So I welcome them all here to today's session. And there has been another decision which Dr. Saxena and I have discussed and taken, that the number of attendees have not changed when we have shifted the web series from Friday to Saturday. So from coming Friday, the next week, we are going to have the mini symposium, the first mini symposium of web series, that is going to be on the 7th of August. And subsequently, the web series will be on every Friday evening, 7 o'clock. That is all. Dheeraj, if you could put everybody on the mute, please. I have muted everybody. So Dr. Maully, please unmute yourself. Dr. Narasimhan and Dr. Amit Vora, please unmute yourself. And over to you, Dr. Narasimhan and Dr. Amit Vora.
Good evening, everybody. And it indeed is really a privilege to be part of this IHRS initiative, and more so because Maully, a good friend whom I personally know for over 2 decades, is going to deliver a rather difficult subject in electrophysiology, is management of arrhythmias and congenital heart disease. Now, before we start, I would like to say that having known Maully for over 2 decades, I find her ageless. She's been the same for the last 20 years, with the same enthusiasm also. She's been very contemporary in the knowledge and approach, and has chosen a very difficult aspect of electrophysiology, that's managing arrhythmias in children and doing complex procedures. Every time you hear her, you become wiser and richer in knowledge. So I'm looking forward to Maully. She is currently the Director of Electrophysiology at the Children's Hospital, Philadelphia. And over to you, Maully.
Thank you very much. That was a very, very kind introduction, and I hope I actually am deserving of your kind words. I want to thank Vanita and the entire leadership of IHRS and members for inviting me to give this talk. Even though I live in the US, the Indian Heart Rhythm Society members are very dear to my heart, and thank you very much. So we have a lot of ground to cover today. If we don't get through all aspects of my talk, I'll end whenever my time is up, and we can continue the session at a later time. But without much ado, my objectives for today's talk, and give me 1 second while I just adjust my screen here, so please bear with me. All right. My objectives today are to talk about difficult accessory pathway substrates in congenital heart disease, talk briefly about the baffling arrhythmias. These are arrhythmias related to the Fontan and Mustard baffle. And then finally, if there is time, I'd like to talk a little bit about ventricular tachycardia, because we've learned a lot in the last 10 years in how to ablate these patients. The most challenging accessory pathways.
Excuse me, Maully.
Yes.
I'm sorry to interrupt, but your slides are not changing. Can you please you can stop sharing and start sharing again.
Let's try again.
Yes, please.
How about now?
No, your slides are not moving. You have to stop sharing, the green button at the top.
Okay.
You stop share, do the stop sharing and then share again.
All right, I'm sorry about that.
No problem. Okay. Please press the, share screen. Yeah. And now you can go to the full screen, the slideshow, please.
How about now?
We can't see the slideshow part. Everybody else is able to see? I mean, are you able
No,
to
I
see?
think it's not coming up in the
Oh.
slideshow view as
Okay,
yet.
give me 1 second again. Sorry, I'm going to try and do it again.
If we can go off all of us can be off video mode. Sometimes we have to just hear Maully and then we can come back to video mode later.
This is actually very, very unfortunate, but let me try it one more time.
Can you increase the slide, the depth of the slide? It is 38%. If you can increase that.
Ah, okay, I see what you're saying.
We may be able to see this.
I think she needs to just put on the rehearse one or slideshow.
Sorry?
If you put on that slideshow, it'll come.
Yeah, I'll please try sharing your screen again, Maully.
Okay.
Yeah.
You can't see anything still, right?
No, we cannot see your slides now. You have to start
Oh,
sharing the screen again.
Oh, okay. I haven't had this problem before, but.
Okay, that's better now. So can you go to the slide sharing option and press that at the right bottom?
You mean slideshow?
Yeah, slideshow, sorry.
Can you see anything now?
We are able to see your slides, but not in the slideshow.
Oh, are you seeing like the presenter view? Is that what you're seeing?
Yes.
Ah, I see. I'm really sorry for this. I'll fix this.
Sure. Your presenter view is actually marked on the top.
Yeah.
Somebody's suggesting press F5. Dr. Saxena, you are there. Please come and help me.
I think maybe she can restart the PowerPoint once again.
It's related to the duplicate screen. That's what Karthikeya.
Yeah, I think that's what it is. I'm going to get rid of dual monitors. Do you guys want to like talk about something and I'll get this set up?
Yes.
Yeah, sorry about that.
Plenty of things to catch up.
Okay, yeah.
Anil and Vanita, you have to fill in now whatever is going to go on for the next couple of weeks. What are your plans?
Yes, so we have a very interesting session coming up next week.
So, Dr. Narasimhan, we had started last week, the first week of July. We had a grand round by Dr. Sanjay Dikshit. So that was our first grand round. And coming week on the 7th of August, that is Friday, we have the first mini symposium on sudden cardiac arrest.
Fantastic, fantastic.
So this will go on like the first Friday of every month. It will be an alternate between a grand round and a mini symposium, whereby we have the faculty presenting and discussing, and it will also have a panel discussion the next week when we are going to have
planning with one of the leading international faculty.
Right. Correct.
Fantastic.
Okay. Yeah, Maully. Yes, that's better.
Perfect. Go ahead.
Yeah.
That looks good.
Maully, looks good. Good job, Maully. Fantastic. Maully, can you hear me?
You have muted her also.
No, I have not.
She's not muted.
She's not muted. She's unmuted.
Maully, can you hear us?
Hello, Maully.
That's better.
Hello, Maully. Can you hear us? Actually, she was called to the hospital. She's actually doing this presentation from the hospital only. She said she was called out yesterday evening. So that's how she's doing it from the hospital itself.
Vanita, one suggestion is
Yes, please.
some of these US meetings that I've been to, now we just record the video and send it to them.
Okay.
But you are available for question and Q&A.
Okay.
You understand?
Right.
That you can always keep it as a backup.
Correct.
You don't have to.
Okay, we'll try that, sir. Next
Yeah.
time we'll try that. Hello, Molly, can you hear us?
All right, still no, is there any
It's good,
change
it's
or
good.
nothing?
Now it's
You
good.
get
Now
out of this presentation mode.
Can I get out of the, if I get out of the presentation mode, will it work?
Yeah, presenter mode.
Is this better?
Yeah, it's okay. It's okay. I think let's continue.
Yeah.
exactly. I think this is
Okay,
fine.
give me 1 second and we'll be done. Just give me one. I know what the problem is here now.
So I can see I saw Dr. Nabar with the background, the entire background of IHRS, virtual IHRS 2020. Now I can't see him, but I think he's in full-fledged mode to, coordinating and doing everything. Hi, Dr. Ashish.
Hi, here I am.
I wanted everybody to see that
Ashish.
virtual IHRS background.
Hi,
that is so
hi, Dr.
beautiful.
Narasimhan.
I think you should make it as a screenshot for all of us.
I did send on
It's
the.
great. Look great.
I sent it on the IHRS app, WhatsApp. I can do it again.
Sure.
It looks beautiful.
Do you people know that? Anyway, I'll talk to you later again.
It's okay, Molly. I think let's continue like this.
Hello, Molly.
All right, is this better?
Yeah.
Is this better now?
Good.
That's
Perfect.
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 Okay,
Perfect.
I'm really sorry about this.
That's perfectly fine.
All right,
Great.
moving on. Okay, so let's do this very quickly now. I'll try and run through the initial slides. So we're first going to talk about arrhythmias and Epstein's anomaly. As many of you know, this is one of the most difficult substrates of accessory pathways for catheter ablation. Accessory pathways occur in about 25 to 30% of patients with Epstein's anomaly, and manifest pre-excitation, or WPW, is present in approximately 50% of patients with AVRT. Multiple accessory pathways occur in 30% of patients. Atriofesticular connections are present in about 5 to 10%, as is AV nodal reentrant tachycardia. Ventricular tachycardia is also present in a small percentage of patients, and sudden cardiac death occurs in 5 to 10% of patients with Epstein's anomaly, mostly due to a combination of atrial and ventricular arrhythmias. For the uninitiated, I'd like to go through the anatomy of Epstein's anomaly. For the ablationist, it's extremely important to understand this. The main anomaly with Epstein's anomaly is that the posterior and the septal tricuspid valve leaflets are not delaminated from the right ventricular myocardium. Therefore, they're plastered down into the body of the right ventricle. The anterior leaflet is free. However, it is a large, redundant leaflet which mimics the sail of a boat, if you will. The true annulus is not displaced. However, it is difficult to find because of the large portion of the atrialized right ventricle. The true body of the right ventricle is underneath the delaminated portion of the septal and posterior tricuspid valve leaflet. Now, looking at this from the epicardial view, the AV groove is mostly identified by the presence of the right coronary artery. And as you can see that the functional edge of the septal and posterior tricuspid valve leaflets are displayed in a caudad fashion, so that a large area of the morphologic right ventricle is actually an atrialized portion of the right ventricle. You can see on transillumination that this is a very thin-walled structure, and this is very important for people who are putting catheters in the heart to remember, because while these pathways are very difficult, catheter manipulation has to be done very gently and carefully because of the risk of perforation. Now remember, the surface EKG of a patient with Epstein's anomaly typically displays a right bundle branch block pattern. Along with the atrialized portion of the right ventricle, even though the coronary sinus, fossa ovalis, and the AV node are normally positioned, the right bundle branch block, along with the atrialized portion of the right ventricle, is diseased and sometimes atretic. This is a 5-year-old patient with Epstein's anomaly, and I think it's important to note here that this patient shows a fairly normal QRS complex, but there is absence of a right bundle branch block. And the teaching point here is an absence of a right bundle branch block equals presence of an accessory pathway. This is the same patient who presented with SVT, and here you can see that during SVT, the patient actually has a right bundle branch block pattern on the EKG. This patient was then successfully ablated, and you can now see that once the accessory pathway has been ablated, the underlying EKG shows a right bundle branch block. And let's try and understand why that happens. And this typically happens because activation of the right ventricle occurs simultaneously in the presence of an accessory pathway with the AV node. And because there's slowing in the atrialized portion of the right ventricle, the pre-excitation of the atrialized right ventricle via the accessory pathway then offsets the typical right bundle branch block pattern, which leads to a pseudo-normalization of the QRS morphology. Accessory pathway location in Epstein's anomaly is typically on the right side. I have heard of some people ablating left-sided pathways, but really the biggest density of pathways is in the right postroceptal, posterior, and posterolateral region. Now, those of us in the audience who have done these cases will share my pain here. As you know, there are multiple difficulties with catheter ablation in Epstein's anomaly. From an electrophysiologic standpoint, this is due to fractionated low amplitude electrograms throughout the atrialized right ventricle. The oblique atrial muscle orientation along the AV groove distorts the activation patterns, and frequently patients have multiple accessory pathways. From an anatomic standpoint, very often the older the patient is, the right atrium and right ventricle, as well as the AV valve annulus, gets dilated and becomes even more difficult to identify the true AV groove. In fact, I like to ablate these patients early when they're young, because by the time they are adults, the annulus is very difficult to locate. Also note that in about 50% of patients, there's a ridge of tissue along the AV groove that impedes catheter manipulation. There's also inability to retroflex the catheter underneath the tricuspid valve because the tricuspid valve leaflets are plastered to the right ventricular myocardium, and the AV groove itself is very thin, and so with an ablation, there is risk of right coronary artery injury. Very often, patients with Epstein anomaly in the cath lab are unstable and are unable to tolerate SVT even at moderate rates. Most patients have a patent foramen ovale with a right to left shunt, and this carries a risk of thromboembolism during an ablation procedure. Here is an example of fractionated electrocardiograms that you find throughout the atrialized portion of the right ventricle. But as you can see here, the fractionation is more continuous in the right postroceptal and right posterior region. And as you go more laterally, the electrograms do begin to separate, because remember, the anterior leaflet of the Epstein's valve is not plastered down to the ventricle. This is a nice example of an atriofesticular pathway ablation that we performed just 2 weeks ago in a 6-year-old. And as you can see here, that the ablation was performed far laterally. And as shown in the electrogram panel, we were able to record a very clean and clear M potential. So these cases are not always hard, but certainly if you're dealing with multiple pathways and pathways in the postroceptal and posterior region, the cases are very challenging. For the young people in this audience, you probably never had the opportunity to use the Cardima microcatheter, but about a decade ago, this catheter was available and made the cases much easier because not only could you locate the AV groove by putting in the microcatheter in the right coronary artery, but it served as a nice reference, especially if you had multiple accessory pathways. Without this catheter, the cases have become quite challenging. But what we've tried to do is really use adjunct modalities. The key to ablating these pathways successfully is to stay on the AV groove. And whether it's using angiography or using intracardiac echo, here you can see in the bottom right panel, you can usually locate the right coronary artery, and the AV groove is along the cross section of the right coronary artery. So when the cases get difficult, either using angiography or an ICE catheter is quite helpful in placing the catheter on the AV groove. Moving along to congenitally corrected transposition of the great arteries, another challenging substrate for SVT ablation. So as you know, in congenitally corrected transposition, there is atrioventricular and ventriculo-arterial discordance so that the right ventricle is in a subaortic location. 2 to 5% of patients with corrected transposition have accessory pathways, but over 25% of patients also have an Epsteinoid anomaly or an actual Epstein's anomaly of the tricuspid valve, which is left-sided in this population. So it's important whenever you are about to ablate a patient with corrected transposition is to first understand the conduction anatomy. And this is a specimen. We've opened up the right atrium here, and we're looking down through the mitral valve into the left ventricle. And I've marked out the pulmonary valve, the mitral valve, and the coronary sinus os. Many patients with corrected transposition will have a rudimentary posterior or a normally situated AV node, but typically that is not connected to the conduction system. There is otherwise a displaced or an additional AV node, which is anterior and superior to the original AV node. And typically this AV node sits behind the pulmonary artery at the superior region of the mitral valve annulus. The anterior AV node typically is conducted or connected to the His bundle and the rest of the conduction system, and it loops around the pulmonary valve to fan into the intraventricular septum. And therefore, it's extremely important to recognize this. You might think you're dealing with a right anterior pathway, and in a normal heart, you wouldn't be anywhere near the AV node on the right anterior annulus. And here you may be right next to the AV node. So really important to recognize where the AV node is. Because of this distortion of the conduction system is quite fragile, and sometimes catheter-induced AV block is caused, and in many cases, it could result in permanent AV block. So this leads us into patients with heterotaxis syndrome and the story of the twin AV nodes related to SVT. Twin AV nodes are most commonly seen in patients who have a combination of corrected transposition and an AV canal defect. And this typically results in a functional single ventricle, and these patients have heterotaxis syndrome. So as described earlier, there are two functional AV nodes. The anteriorly located node is related to the corrected transposition part of the substrate. And there's also a posterior AV node that is in the usual location. So let's look at our cardiac morphology again. We have two AV nodes, but unlike corrected transposition by itself, where the posterior AV node was not connected to its own conduction system with twin AV nodes, both AV nodes are connected to their own conduction systems. And to make matters even more complex, sometimes there is a network of fibers that connect the two AV nodes. This is known as the Menckeberg sling. And now you can see how this is a substrate to set up multiple reentrant tachycardias between the two AV nodes. So what are the criteria for twin AV node tachycardia? For the younger or the more junior people in the audience, I think it's important to make the semantic distinction that this is not dual AV node. This is twin AV node, so we're not talking about AVNRT with dual node physiology. We actually have two distinct anatomic entities. The criteria for twin AV node tachycardia is one, the existence of two discrete non-pre-excited QRS morphologies during sinus rhythm on the ECG. And here you can see in lead 2, without any change in the atrial rate, we have intermittent changes in the QRS morphology. There is decremental conduction in the antegrade as well as the retrograde direction, and there is AV block and VA block when adenosine is administered. Inducible SVT occurs with antegrade conduction over one AV node and retrograde conduction over the second AV node. So this is a patient of mine, and here you have a very clear demonstration of two QRS morphologies. As you can see in the left upper panel, during sinus rhythm, the patient flips between QRS morphology 1 and 2 without any change in the heart rate. In the left lower panel, the patient actually goes into SVT utilizing QRS morphology 1. SVT terminates spontaneously, and the patient remains in sinus rhythm with QRS morphology 1, but then simply flips into the second QRS morphology. So when we take these patients to the EP lab, the biggest challenge really is not ablating the tachycardia, but really trying to map the two AV nodes. Most of these patients, as I mentioned before, have Heterotaxis Syndrome with a single ventricle, so they have a Fontan baffle. And as I will discuss later, it's extremely difficult to put multiple catheters through Fontan baffles. But regardless, in this patient, as you can see, we are pacing the atrium to induce one type of QRS morphology during ablation. Our strategy here is to determine the Wenckebach cycle length of both AV nodes, and we would like to ablate the AV node that has weaker antegrade conduction. So typically during SVT, the AV node that conducts in a retrograde manner has weaker antegrade conduction. So here with atrial pacing, we're coming on RF. And as you can see, we now have a few junctional beats. And immediately after the junctional beat, we're still atrial pacing. And now we have eliminated AV node 1, and we're conducting through AV node 2, albeit with a slightly longer PR interval. So it's very, very important to identify what you're ablating. and really to make sure that you're actually ablating the AV node, which has the best antegrade conduction. Moving ahead to baffling arrhythmias. These involve baffles, the Fontan baffle, and the mustard and setting operation. Many of you have seen some of these cases before. I'll try and be brief. But these are very challenging cases. Once again, for electrophysiologists, it's not the electrophysiology that's baffling, but it's really the access into the heart that deserves a lot of attention. Since Francis Fontan's first successful operation for the single ventricle patients in 1970, there have been many types of Fontan modifications. And currently, we have moved away from the atriopulmonary Fontan that you see in the left panel. And most of our patients have either a lateral tunnel Fontan or the total cavopulmonary anastomosis using a lateral tunnel baffle or an extracardiac Fontan, where once again, a total cavopulmonary anastomosis is created with a baffle that is completely outside the heart. Now, the risk factors for developing atrial arrhythmias is directly proportional to the type of Fontan and the duration of follow-up. As you can see in this survival curve, in patients with an atriopulmonary Fontan, by 10 years after surgery, only 40% are free of atrial arrhythmias. Whereas in the lateral tunnel and the extracardiac tunnel, almost 90% are still arrhythmia-free 10 years after the operation. However, in all Fontan groups, the longer you follow them, ultimately, more than 50% of these patients will develop some type of atrial arrhythmias. So I'm not going to go into a lot of detail about access, but for electrophysiologists who are going to treat patients with congenital heart disease, it's extremely important to obtain skills for transbaffle access. As shown here, in a lateral tunnel, the transbaffle access is through a baffle, which is intraatrial into the pulmonary venous atrium. In an extracardiac Fontan, the baffle puncture is through an extracardiac conduit into the epicardial surface of the right atrium, and then through the right atrium into the pulmonary venous atrium. So I always feel that if you're going to take a Fontan to the EP lab, either the electrophysiologist as a primary operator must be able to access these baffles, or have an interventional cardiology colleague in the lab to help out with access. Additionally, the heterotaxy patients often have an interrupted IVC, so there is really no direct access from the femoral vein into the Fontan baffles. And another skill to learn is to be able to obtain transhepatic access. So Fontans are considered sort of the multi-headed hydra and the most complex of all catheter ablations. And rather than dwell on the complexity of these arrhythmias, I have always taken the stand that we should make all complex ablations as simple as possible. So this is how I approach Fontan ablations. The first is to read the operative note and determine what type of Fontan the patient has. For atriopulmonary Fontans, the arrhythmia substrate is usually in the right atrium, but we must be prepared to map the left atrium. In a lateral tunnel Fontan, the arrhythmia substrate is usually in the pulmonary venous atrium, which is the morphologic left atrium, but the lateral tunnel should also be mapped. And in an extracardiac Fontan, only the left atrium or the pulmonary venous atrium needs to be mapped, and that is accomplished by a transbaffle transatrial puncture. This is an example of an atriopulmonary Fontan. You can see that the right atrium here is actually bigger than both ventricles combined with a volume of 210 cc's. And so these are extremely challenging arrhythmias. I think it's important to note that the arrhythmia substrate can be anywhere in this dilated atrium. But however, if there is a cavo-tricuspid isthmus that can be identified, even if the tricuspid valve is rudimentary, it's important to map the cavo-tricuspid isthmus. The typical way that we approach these is to really tag all the scar areas in the dilated atria, find channels of conduction, and try and homogenize the scar until arrhythmias are not inducible. So once again, in Fontan's, the 3 pearls I have for everyone here, and you'll be successful with at least 75% of your cases, is never take the CTI for granted. Never assume that the CTI is the culprit just because it is there. At the same time, never leave the EP lab with the CTI open. This is an example in my earlier years of an atriopulmonary Fontan. I was very proud that we were able to tag the big right atrial incision, and we found the re-entry around this atrial incision. We ablated the tachycardia and sent the patient home. 3 months later, the patient then comes back with intraatrial reentrant tachycardia. And while we had blocked the isthmus between the IVC and the right atriotomy, we had not done an isthmus ablation. And so during this case, the reentry was around the rudimentary tricuspid valve. So really important, don't finish the ablation until you've made sure that the cavo-tricuspid isthmus is ablated. So what's my approach to these complex patients? Again, I think we're more successful when we try and simplify the most complex procedures. And just as you would deal with any scar substrate, the first aspect of a Fontan ablation is to really understand where the scars and where the anatomic obstacles are, and then tag them on your 3D mapping system. Once you induce an atrial arrhythmia, you want to make sure whether it's a macro reentrant or a focal reentry. Ectopic atrial arrhythmias do occur with Fontans, but focal atrial reentrant tachycardias are much more common. You want to ensure that your induced atrial tachycardia cycle length is within the activation map, or at least 95%. It occupies 95% of your activation sequence. And you know, it's really important not to get fooled by these early meets late maps. And every time we see an early meets late map, instead of just ablating there, we really look at our local atrial activation timings. And here you can see that we've tagged a point which is a little more proximal to our early meet late site. And we are going to evaluate our local atrial activation time. And indeed, our local atrial activation time is later than the P wave at this point. We now move the catheter a little bit closer. And you can see in the left panel that the atrial electrogram is diminishing, but the local atrial activation time is now getting earlier. And with minimal catheter movement here, we're now suddenly early than our previous point. And this gives me great confidence that we are in the circuit here. Once again, I'm a big fan of entrainment. I know people feel that entrainment sometimes causes problems, but in my experience and practice, especially for scar-related tachycardia, always entrain before ablation. So here we have a tachycardia cycle length of 294 milliseconds. We are In training here, we have a post-pacing interval of 303 milliseconds. You want to make sure you're not in the outer loop, so you want to make sure your stim to atrial electrogram is equal to your electrogram to a reference catheter or your P wave. And here we have great agreement between the two. This would be a very satisfying site for me to ablate. And here, an ablation lesion in this region terminates tachycardia. Once again, we should not be satisfied with just termination of tachycardia. It's important to complete your ablation line so that you're finally going to be able to test for bidirectional block. Moving onwards to arrhythmias after the atrial switch operation, and this is for patients with transposition of the great arteries, patients who've had the mustard procedure or the Senning procedure. And once again, this is a very complex baffle procedure. And the reason I want to show you this EKG is that this is one substrate where the EKG morphology tells you absolutely nothing about the arrhythmia. So as you can see here, we have these fine P waves in some leads, and someone might think that this is atrial fibrillation, but because of the complex baffling, there is attenuation of the electrical signals, and the surface EKG virtually never records a dominant P wave. So really the point of this EKG is that all this tells you is that there's an atrial arrhythmia. You can't tell where it's coming from, or you can't even tell if it's atrial tachycardia, if it's intraatrial reentrant tachycardia or atrial fibrillation. For those of you who are new to congenital heart disease, just very simplistically, the way this operation is done, through a large atriotomy, the atrial septum is removed, and a pericardial baffle is sewn to the SVC and IVC, very much like the trousers of your pants. And the waist is then sewn to the mitral valve. In this way, the venous blood is now diverted through the mitral valve into the subpulmonic left ventricle, and the pulmonary venous blood then goes through the tricuspid valve into the subaortic right ventricle. So why is understanding this operation important? Reading an op note in a patient who's had a mustard procedure makes the difference between being in the lab for 3 hours versus 10 hours. So it's really important to understand how the surgeon has sewn the baffle. As shown here, if the inferior baffle suture line is sewn to the eustachian valve, then the septal isthmus and the coronary sinus os are now relegated to the pulmonary venous atrium. Therefore, the only way a cavo-tricuspid isthmus can be ablated successfully in this case is to access the pulmonary venous atrium. However, if the suture line is now moved and placed in the mid portion of the tricuspid valve IVC isthmus, the septal isthmus and the coronary sinus are now in the systemic venous atrium. And this would tell you that you actually have to perform a biatrial approach. Again, in a patient with an atrial switch operation, the arrhythmias are not simply relegated to the peritricuspid region. Because there are suture lines near the SVC and the IVC, intraatrial reentrant circuits can occur in the systemic venous component of the heart, as well as in the peripulmonary vein component and the periatriotomy component of the myocardium. So again, this is a very simplistic way of showing a mustard operation as it relates to intraatrial reentrant tachycardia circuits. We're looking into the pulmonary venous atrium, into the tricuspid valve here. Here is the baffle suture line. And here is the atriotomy. So now we can have reentry around the tricuspid valve, around the atriotomy, and also a figure of 8 reentry. Another important aspect of atrial arrhythmias in patients with DTGA is that they have very healthy AV nodes, almost exquisitely healthy, as though they have enhanced AV node conduction. And as you can see here, this patient is in a 2-to-1 tachycardia and abruptly starts conducting 1-to-1. The risk of intraatrial reentrant tachycardia is much greater than any other form of congenital heart disease because of the risk of sudden cardiac death. Because of the extreme Baffle lines, the tachycardia cycle lengths are relatively long. These patients have healthy AV nodes. Most of them are young, active patients. And because the systemic ventricle is a right ventricle, they have inherent ventricular dysfunction and impaired coronary perfusion. And here's an example of a patient with intraatrial reentrant tachycardia who's getting induced in the EP lab with anesthesia. His catecholamines increased, and now he is conducting 1-to-1. As his catecholamines increase further, we now have ventricular tachycardia, and he becomes hemodynamically unstable before I had a chance to even put catheters in. And fortunately, he was in the EP lab, and we were able to cardiovert him. But you can see how this can happen outside the hospital, where a 2-to-1 tachycardia or a 3-to-1 tachycardia can very rapidly degenerate into a 1-to-1 tachycardia, inducing ventricular tachycardia and sudden cardiac death. So just generally, most of the critical areas for ablation in patients with an atrial switch operation are around the tricuspid valve. And as you can see on my right, this is a Bi-Atrial Propagation Map of the intraatrial re-entry. On the left-hand side, we have an activation map. And once again, even though the maps look great and we have great early meets late signals, always want to entrain before ablating. So once again here, we have an atrial cycle length of 298 milliseconds. We have a PPI after entrainment of 300 milliseconds. We have a very long stim to P interval. I like this a lot. Long stim to P intervals, which means that we are further back into the isthmus. The stim to A interval matches with my electrogram to P wave. I'm in the circuit here, and this would be a very good site to ablate. Once again, I'm not going to belabor the access part, but these ablations are really challenging, not because of the electrophysiology, but because of the access. So as shown here, the systemic venous atrium can easily be accessed in your routine fashion. However, in order to access the pulmonary venous atrium, either we have to go retrograde up the aorta through the systemic right ventricle and back up against the tricuspid valve. And I tell my fellows to really master this maneuver because it's absolutely essential for ablating a mustard or ascending patient. Recently, we've been doing a lot of transbaffle punctures. These are actually pretty easy to do, especially with intracardiac echo. You can really make sure that you're right on the baffle when you puncture through. And once again, if you're using intracardiac echo, the first thing you want to look for are baffle leaks, because that's a gift. Then you don't really have to perform a baffle puncture. As shown in my left upper panel, this patient already had an intra-baffle leak. I saw that with intracardiac echo, and I'm just going to track my catheter through the baffle leak without having to do any additional procedures. Intracardiac echo is also extremely useful because, as shown here, you can actually see your catheter sitting on the isthmus. This is actually through a retrograde approach. Without this, through fluoroscopy, I wouldn't really know where I am. And here I can actually see my catheter. I can almost see the edema forming on the isthmus, and I know I'm getting good radiofrequency energy here. So what happens if we terminate our intraatrial reentry with RF? Are we done? So first of all, these arrhythmias, even though they're complex, if you're in the critical isthmus, they terminate very easily. But that doesn't mean that you are done. And this is just a simple way in a Fontan, as well as in a mustard. You can put a multipolar catheter on both sides of the isthmus and assess pre-ablation CTI conduction before the case, and then assess CTI block after the case. So all you have to do is pace from different sites of the pulmonary venous and the systemic venous side of the cavo-tricuspid isthmus and confirm bidirectional block. So another important aspect to remember is when you do these ablations, how do you know that you're not going to cause heart block? And again, it all depends on where the surgeon has sewn the inferior part of the suture line. So you really want to, if the surgeon has sewn the inferior baffle suture line to the coronary sinus, the slow input to the AV node may already be disrupted. And therefore, anytime you have a patient with a long PR interval on an EKG, and when you put in a ventricular catheter and there's no VA conduction, and you're taking this patient for an atrial flutter ablation, which is dependent on the cavo-tricuspid isthmus, you want to avoid the septal isthmus as much as possible. Otherwise, you're going to get heart block, as you can see here. All right, we're going to switch gears and talk a little bit about ventricular tachycardia. And I'm going to use tetralogy of Fallot, even though VT can occur in almost any form of congenital heart disease where there's a ventriculotomy or a VSD patch. And I want to talk about tetralogy of Fallot because we have learned so much about ablating this substrate in the last 10 years. And just as an overview, approximately 8 to 10% will develop ventricular arrhythmias over long-term follow-up. The mechanism is usually reentry, and these are actually very stable arrhythmias to map and ablate. We've known for years that the reentry circuits are related to the VSD patch and the right ventriculotomy and the right ventricular outflow tract patch. But it's only in the last 10 years that we have really been able to understand and identify what the anatomic isthmuses are. And the reason these anatomic isthmuses are important is that if you look at the number of patients that you take to the cath lab with intention to treat ventricular tachycardia, in 10 to 15%, the VT is non-inducible, so you don't know what to do. In another 10%, either the patients have lost their femoral vein access because of years of catheterization and there's no way to get into the heart, or there's a high-risk location, or in another 10%, the VT is unstable and you have to cardiovert the patient and you're done. So with different mapping techniques, while we have really increased our ablation success, what we've learned mostly is how to map the anatomic substrate without inducing VT. So I'm going to very briefly touch on other aspects of mapping VT in tetralogy of Fallot, but really talk about pace mapping and substrate mapping. So I'm really not going to talk about activation mapping because you are all experts with your three-dimensional systems. I think for the more junior electrophysiologists, it's important to understand that while mid-diastolic potentials are important, and they are observed at 50% of the isthmus sites, they can also be recorded at bystander sites, and sometimes potentials simply represent far field activation from depolarization at remote sites. So while very attractive, you really have to make sure that they're part of the critical reentry circuit. And Again, as I said, as with atrial arrhythmias, I'm a big fan of entraining any type of reentrant ventricular tachycardia in congenital heart disease. There are some arguments for and against this because of degeneration from one tachycardia to another, but I typically don't feel confident just relying on my 3D map. So I'm assuming that we have an audience of electrophysiologists here, so I will not go through Bill Stevenson's elegant description of entrainment and scar-based arrhythmias. But again, as an example, here we're in a monomorphic ventricular tachycardia. Our tachycardia cycle length is 410 milliseconds. We have a very pleasing PPI. We have a good match between our stim to QRS and our EGM to QRS. And again, very, very good site for ablation here. Now, what about pace mapping? So pace mapping, again, is fraught with advantages and disadvantages. Pace mapping usually, we usually pace map around potential exit signs along scar borders. Remember, the pace QRS configuration may differ from VT even if you're in the circuit, because reentrant wavefronts exiting the scar may be broad. Circuits may have multiple exits, and pacing may be performed at the isthmus entrance or the inner loop. But typically we want to look for a conduction delay or stimulus latency of at least 40 milliseconds to really feel confident that we're anywhere near the reentry circuit. So a case and example, this is a 23-year-old truncus arteriosus repair who had multiple surgeries for conduit replacements and multiple transcatheter interventions. He came to our emergency room with hemodynamically significant syncope. He had an electrophysiology study during which multiple VT morphologies were induced, but he became hemodynamically unstable during the case, so we couldn't really perform any type of ablation, and an ICD was implanted and he was sent home, and lo and behold, a year later, he has an ICD storm. This will just give you a view of what his heart looks like. Remember, in congenital heart disease, atrial and ventricular arrhythmias have a hemodynamic correlation. So while scars, patches, and suture lines can create reentry circuits, those circuits are not triggered unless there is a hemodynamic problem. So we always, always, always want to perform a cardiac catheterization to ensure that our patient does not need any hemodynamic interventions before we proceed for an EP study. And in this patient, his hemodynamics were actually pretty good. So this is one of his morphologies that he presented to our emergency room with. You can see that there's a monomorphic ventricular tachycardia at 190 beats a minute. These were the 3 VT morphologies that we induced in the lab when he became hemodynamically unstable. So VT1 was a left bundle branch block with a left superior axis and a precordial transition in V6. VT2 was again a left bundle with a left inferior frontal axis with an R2S transition in V6. And VT3 was a left bundle branch block, left superior axis with an R2S transition in V4. So really, if you look at VT1 and VT3, the R2S transition is where we see some differences. So in view of the patient's ICD storm, we did take him back to the lab, but we didn't want to repeat our previous procedure. So instead of trying to induce VT, we relied on substrate mapping. Now, as you can see here, and I've shown you multiple views here, this is the patient's right ventricular to pulmonary artery conduit base, and the entire region at the base, all the way to the tricuspid valve annulus is scar. In this disease, the patient does have a native right ventricular outflow tract too, so it's almost like a double barrel. But most of the pulmonary blood flow is going through the right ventricular outflow tract conduit. You can also see the rest of the ventricle is actually pretty healthy here. So we proceeded to pace map along the scar as we discussed. And as you can see here, pacing near the native RVOT really didn't give us a great pace map here, but now we are pacing at the base of the conduit here, and we can see that at a few sites we have almost 12 out of 12 pace map on the surface EKG. However, our stim to QRS is about 40 to 50 milliseconds, so we're probably just at the exit site here. Similarly, we paced near the tricuspid valve annulus for VT1. This was the superior axis, QRS axis with transition in lead V6. And once again, really good pace maps at the tricuspid valve annulus between the scar of the right ventricular outflow tract and the tricuspid valve annulus. And similarly for VT3. And the beauty here was that while we were pace mapping for VT1 and 3, you can see there that with one drivetrain, this is our pace mapping site. Here we have VT1 here, early transition. And with the same drivetrain, we have more stimulus latency here. And now we have a pace map that matches VT3. So same drivetrain, and this is probably a multi-exit site. As you know, this is usually critical for re-entry. And once again, not relying on pace mapping alone, we perform entrainment here, and we have a cycle length of 414 milliseconds. We have a good PPI, and we determine that this is an isthmus site, and first RF terminates this tachycardia. So moving along to tetralogy of Fallot, and we owe a lot of what we understand today to Katja Zeppenfeld and her colleagues, who has painstakingly identified 4 anatomic isthmuses in patients repaired with tetralogy of Fallot. And it's important to really look at the operative notes to understand what type of repair they have to make the cases simple. So what we call anatomic isthmus 1 is the isthmus between the right ventricular outflow tract patch to the tricuspid valve annulus. Isthmus 2 is between the right ventricular outflow patch to the pulmonary valve. Isthmus 3 is between the VSD patch to the pulmonary valve, and isthmus 4 is from the VSD patch to the tricuspid valve annulus. And to show this in a true specimen, as you can see here on my left, the right ventricular outflow tracts in the older days were performed by really sewing on these very large patches to the outflow tract of the right ventricle, or creating large ventriculotomies and ventricular incisions. And when we open the heart, so this is basically, we've opened up the right ventricular outflow tract, and you can see isthmus 1 is between the tricuspid valve annulus and our RVOT incision here. Isthmus 2 is between the right ventricular outflow tract incision and the pulmonary valve. Isthmus 3 is between the VSD patch and the pulmonary valve. And isthmus 4 is between the VSD patch and the tricuspid valve annulus. Isthmus 4 is probably the least common, thankfully so, because the conduction system of the heart in tetralogy runs along this inferior border of the VSD patch. The most common isthmuses, depending on the type of the repair, are Isthmus 3 and Isthmus 1. Now, in the last 2 decades, most surgeons perform this operation by a transatrial repair using a very small transannular patch. And you can see by just changing the surgical technique, we are now eliminating Isthmus 1 and Isthmus 2. So any patient who's had a transannular patch via a transatrial approach, we're really dealing with Isthmus 3 and Isthmus 4. This is a 3D anatomic map showing a voltage map of the isthmuses that I just described. And as I've outlined them, you can see Isthmus 1, 2, and 3, and 4. And it's really understanding where your reentry circuit is in order to perform a substrate-based ablation without induction of VT. So there are 4 important definitions for substrate mapping in tetralogy of Fallot. First is to understand the isthmus width, which is the distance between 2 unexcitable anatomic boundaries. And in tetralogy, this is usually an incision and a patch. The isthmus length is the distance in millimeters between normal electrograms recorded at the entrance and exit sites of the anatomic isthmus. The conduction time through the anatomic isthmus is extremely important, and we'll talk a little bit about that. This is the difference in local activation time between the entrance and the exit of the anatomic isthmus, and the conduction velocity index is the length of the isthmus divided by the conduction time. And why is this important? Because as I showed you, depending on how the surgery is performed, anatomic isthmuses are bound to exist. However, we need to determine, are these anatomic isthmuses pathogenic or arrhythmogenic? And again, the same group has done some really exquisite work defining what a conduction velocity index through these isthmuses is. And as you can see here, we have these 10 millisecond isochronal activation times. And if the activation time between the entrance and the exit is delayed, and they've actually come up with a critical value, then that would determine whether this anatomic isthmus actually has slow conduction. And is that where the VT is coming from? So this group has shown that if the conduction velocity index through the anatomic isthmus is less than 0.5 meters per second, then this correlated with VT induction and a pathogenic isthmus. Again, shown here on the left 2 panels, we have 2 anatomic isthmuses. We have 2 anatomic isthmuses, Isthmus 1 and 2. And if you look at the left upper panel, the electrograms recorded within the isthmus are completely normal. The activation time, the local activation time is completely normal. And these isthmuses were therefore not correlated with ventricular arrhythmias. However, if you look on the 4 panels on your right, and this is through anatomic isthmus 3, which is between the VSD patch and the pulmonary valve, the only electrograms that are normal are those recorded in panel A and D, which are the entrance and exit sites. Throughout the isthmus, what you're seeing are continuous fragmented electrograms. So just having an anatomic isthmus is not equivalent to ventricular tachycardia. You have to demonstrate that there are abnormal electrograms and that the conduction velocity through this isthmus is less than 0.5 meters per second. Now, what about, we're all interested in EKGs. Can we look at the EKG and can we figure out what our anatomic isthmus might be? It's not that simple. But we have some clues. So we can look at the bundle branch block morphology in VT. We can look at the frontal plane QRS axis. For the purpose of tetralogy of Fallot, we typically look at lead V5 for early versus late transition. And then we also look for precordial transition break in V2. So as shown in the upper left panel, we have a right bundle branch block tachycardia with inferior axis, and there's positive QRS concordance across the precordial leads. And in this patient, this correlates typically to anatomic, even though it's a right bundle branch block, and 25% of tetralogy of fellow patients will have a right bundle branch block morphology VT. This always correlates to anatomic isthmus 3. Anatomic isthmus 3, if you had to pick one isthmus to go after, is the most common isthmus. But here, this also tells you that your breakout is in the right ventricular septum. However, if you look at figure B, also right bundle branch block, inferior axis, but you have a transition break here in V2. You have a transition break right here. So again, when you see this, the anatomic isthmus involved is isthmus number 3, but this tells you that you might have a left-sided break. So the septal break might be on the left side, and when you see this, it's important to map the left side. Otherwise, with left bundle branch block morphology, if the transition is earlier than V5, most likely, again, the anatomic isthmus is going to be anatomic isthmus 3 between the VSD patch and the pulmonic valve. And without induction of VT, you can ablate that isthmus if it meets the criteria for being a critical isthmus. However, if the transition is later than V5, then any other anatomic isthmuses may be involved. So not that helpful. So this will be my last slide. Thank you very much for your attention. I really apologize for all the technical problems I've had. You'd think I would have mastered Zoom meetings by now, but I changed my computer, and I'll take any questions. Thank you.
Thank you very much, Maully. In the interest of time, I'll just, there are quite a few questions. Number one, is there anything specific about anesthesia in children to prevent non-inducibility?
Great question. I do think that if children were allowed to breathe with a normal airway, the amount of anesthetic that they require can be modified. Typically, what I feel is when our anesthesiologists intubate our patients and paralyze them, they also seem obviously increase the depth of anesthesia. So I think maintaining a natural airway, if possible, is good, and propofol works pretty well for long cases. But yeah, unfortunately, anesthesia is not always our friend. But I think maintaining a normal airway has helped me.
Second, is there any specific hardware for younger children, 10 kg and below?
So, no. What I do to eliminate one catheter is I always use transesophageal pacing for my reference catheter as well as for atrial pacing. So that eliminates one catheter. I know I've heard Yash saying that you guys have like some 5 French ablation catheter in India, but we don't. We only have a standard 7 French catheter here. So yeah, we can eliminate one catheter with transesophageal pacing.
Anyway, MRI, so pre-procedure CT and MRI, what is the role?
So, you know, what has happened is there was a time when we were getting pre-procedural CT and MRIs just for procedural planning for many years. The way pediatric cardiology has evolved now is that almost every patient from their general cardiologist always has an MRI almost every 2 or 3 years. So we've never had to really get it specifically for our procedure. We do review the MRI to understand the operation. And I really rely on EP-based scar mapping rather than what they show me on MRI. So, you know, if I can't pace at my maximum output, then I know, and if I have good contact, I know I'm in a scar area. So I rely on MRIs more for anatomy than for scar.
question about Epstein's patient who are going for surgery with no SVT, history of SVT. You
Yes,
perform
always take
study
them to the lab. Always take them to the lab
before the surgery.
before the surgery, because we've all burnt ourselves. Depending on the surgeons you work with, most surgeons think they can fix everything, and once they put in a valve, I've actually been able to ablate some pathways through a bioprosthetic valve, but certainly not what you want to do. So every patient with Epstein's before surgery should have an EP study.
Even if there is right bundle branch block on the ECG?
Yep, because you could have a concealed accessory pathway.
Okay. Amit, quite a few comments from Dr. R.D. Yadav, but they're kind of, most of them are emphasized about your fractionation and mustard and so on and so forth.
Maully, as always, a very lucid talk, and we would keep on listening to and learning from you. Tell me, in ventricular tachycardia and congenital heart disease, now, what is the first approach, especially even TOF? Now, they develop ventricular tachycardia much later. They are relatively adult congenital heart patients. Is ICD as a first choice, or radiofrequency ablation of the VT the first choice?
So this is a great question, and I'm glad you asked me, because I couldn't cover this aspect in the time I was given. So the first thing I think we want to clarify here is that just like an Epstein, before they go for their tricuspid valve procedure, any tetralogy of patients, before they go for, if they've had ventricular tachycardia, before they go for pulmonary valve replacement, either transcatheter or surgically, should probably have their VT ablated. There's very good data coming out of the adult congenital heart disease world now that, sort of the old philosophy that just replace the pulmonary valve and the arrhythmias will go away has not borne out. So most of the time, unless it's a very stable, if it's a very stable VT and you're sure you can ablate it, maybe I won't put an ICD in a patient, but typically we do the ablation and then back it up with an ICD.
Thanks. There are some
So
questions.
ablation first. Yeah.
Okay. Are there any, there were some papers earlier, are there any ECG markers in post-operative tetralogy of fallow which will predict a high risk for sudden cardiac death in VTs?
Yeah, like people have made their career on this QRS duration. We just weren't that, yeah. I mean, I have a lot to say about that, but I'll just minimize my own thoughts. Really, it's the QRS duration really just reflects RV dilation, right? The bigger your RV, the greater the dispersion of depolarization and wider the QRS. So I think, that's Andrew Reddington and Michael Gatzoulis really had like a decade of, we've implanted at least 24 ICDs based on that QRS duration with absolutely no arrhythmia. So I think the QRS duration by itself is not a risk factor. I think what we need to use is a composite score. And one of the most important markers for sudden cardiac death is left ventricular dysfunction and elevated left ventricular diastolic pressure. So I would rely on that more than QRS duration.
There are some questions regarding, doing a transeptal puncture in a baffle. Can you just briefly give a comment on how to go about it?
Yeah. So first, you want to make sure you have good tools. We started out doing transbaffle punctures with a regular Brockenbrow, and it works, but not in all the cases. The older the patient, if the baffle is calcified, it's a real challenge. If you have an RF needle, I think that's the best way to go. Just remember that you really need to understand the anatomy, because we're all used to doing transeptal punctures in an atrial septum. Remember, the baffle in a Fontan is from the IVC to the SVC. So you don't want to be very posterior, right? Because all all your substrate is actually anterior to the vena cava. So that's why I think if you can use intracardiac ice, I really feel like that's my third set of eyes is intracardiac echo, because you can really see where you're puncturing. The puncture is very standard, just like using a Brocken brow. Wherever you might have to sometimes bend the needle a little bit so you can catch onto the baffle. These baffles are very smooth, and you could just sort of run the needle through the baffle and never catch on to anything. So bend the needle a little bit so you can catch on. The needle will go across very nicely, as does the dilator. The sheath sometimes sticks at the baffle, and most of you are great with coronary artery work. We usually just use a coronary balloon to dilate the opening a little bit to let the sheath through if it doesn't go through. But using intracardiac echo is so helpful.
Well, there are some questions coming up beyond what you spoke, because everybody would like your feedback in terms of, what about CRT procedures in children, and do you at all consider his bundle or a left bundle pacing in the in young?
So that's a great question. I think CRT is much more common, just because we want to protect the subclavian veins for longevity. Most of the CRT procedures in children are epicardial procedures. So really, we don't do CRT until patients are like about 30 kilos to put in 3 leads. I think his bundle pacing and left bundle pacing is a new frontier for us, and we're all very interested. So I think there is very little experience in congenital heart disease and in the pediatric world, but that's where the field will move, because as I said, CRT right now means you've got to have your chest cracked open.
Narasimhan, you have any other questions, comments?
No, I think what I've realized is we should probably have one more session with Maully. It's unfair to have everything covered during this short time. Probably a little later, we'll have some more questions from all our colleagues, and then we'll have probably a month later. Thank you very much. That was a wonderful summary, Maully.
Thank you very much, and I'm happy to share my email, or Vanita can share my email if anyone has any questions or anything that I didn't cover during this talk. Please feel free to email me. This is a topic really dear to my heart, and I know in India, congenital heart disease surgery is almost every center is performing it. So whether you like it or not, you're going to have to deal with these patients. And I'll be happy to help in any way.
Great.
Thank you so much, Dr. Maully. It was excellent presentation, and I will definitely share your email address, and whatever feedback we have, we will definitely I'll share it with you in the questions on the chat. I'll send them, whichever have not been covered. Secondly, yes, I do agree with Dr. Narasimhan. We need another session with you, so we'll be troubling you soon again. And thank you so much. Yeah. Thank you so much. Dr. Saxena is here. Dr. Saxena, you want to add something, please?
Thank you so much. Thank you, Maully, for an excellent session. Thank you.
Thank